Hi guys, Assalamu alaikum. I am Mohammed Shamoon. I'm a second year medical student, and today we are going to be going over the MSK OSPE review. So I'm going to be teaching you the upper limb portion of it, and then Samra is going to continue with the lower limb. So before we get started, if you guys have any question after the end of session, please feel free to reach out to me or Samra. Our contact details are provided. So without further ado, let's get started. So what I'm going to be doing today, the way we're going to approach the upper limb is first, we're going to do some clinically relevant information related to OSPE. That's definitely going to help you in the MCQs. But right now I will be more focused on OSPE though. And then we are going to be doing the questions related to OSPE. So histology, anatomy. So it's not going to be exactly same like a live session, but I'm going to try to make it as interactive as possible. Okay, so let's start. So first of all, let's start with clavicle. So I'm pretty sure you have done this in the anatomy lecture. So clavicle is just a modified long bone, and the important thing about it, it's usually fractured, and the fractured has this particular type of swoosh. So like you basically fall on this on your like outstretched hand that leads to the fractured clavicle. Now the clavicle is divided into two parts, so it's two-third is the anterior, or the not the anterior, proximal, and the one-third would be the distal. So two-third is proximal, one-third is distal, and then we have the anterior aspect of it, posterior, superior, inferior. We'll get into it. But before that, so the clinically relevant info about the clavicle is that usually the most common fracture part of the clavicle is the medial or the proximal two-third. Okay, so that's the thing. And the second thing is that the sternocleidomastoid muscle, when the clavicle is fractured, that's the muscle that pulls it up, and the latissimus dorsi pulls it down. Okay, so you just need to remember these two muscles. One of them can come up along with the fracture. So yeah, now let's get into the clavicle. So as you can see, this is the clavicle. So the thing they can ask you in OSPE is that identify the sternal end or the acromial end, or they can say that what's something particular about the superior and inferior surface, or the anterior or posterior. Like how can you say that, yeah, this is a clavicle, or this is the anterior part of the clavicle. So first of all, let's get into the anterior and posterior. So the anterior would have this uphill kind of thing. Let me draw it. So as you can see, this is like an uphill, okay? And posterior would be a downhill kind of thing. So if you hold it posteriorly, you're going to see a U or a U-turn kind of shape, or a downhill, but interiorly it's going to be going up and down, okay? And then superior and inferior surface. So the particular thing about inferior surface is that it has this depression, which we call it a subclavian groove. So this is the subclavian groove I'm talking about, and the subclavian artery runs through it. And now it's for the identification for whether it's a sternal end or the acromial end. You can identify it by this conoid tubercle, which is for the identification for the acromial end. Okay. And sternal end is basically it's gonna join with the sternum, so that's pretty obvious by the name itself. Okay, so let's move forward now for this slide. So the most important thing about this is the supraspinatus, and as you know, that supraspinatus is part of the rotator cuffs. Now, what are the rotator cuffs? I'm pretty sure you guys know it already. So we have four rotator cuff muscles, which are on the head of humerus, or which attach to the head of humerus. So first one is subscapularis, supraspinatus, infraspinatus, and teres minor. Okay, so these four are the rotator cuff muscles, and they are primarily involved in the basically they are the like main muscles for the abduction, so abduction, so like moving it away from your body. So that movement, okay, along with so the main muscles of this movement, the abduction, would be the supraspinatus. It's going to be deltoid, trapezius, and serratus anterior. And one more thing about supraspinatus is that it's for the initial 15 degrees of the abduction, or initial abduction, okay? And the deltoid is for the rest of the abduction. So after the 15 degrees, it's done by deltoid, but the initiation is done by the supraspinatus. So that's a buzzword or a keyword for you. And whenever you see someone cannot initiate the abduction of their arm, that's definitely going to be a supraspinatus injury. Okay. And the injury could be a partial tear, it could be a sprain, it could be degeneration, atrophy of the muscle. Okay, it could be anything. But the problem would be they won't be able to start the abduction, and it's gonna be painful. Okay. Now, one of the most important slides for MSK itself, not just the OSPE, it's like for the whole MSK. Okay, this is really, really important. I can't emphasize on this more. The thing is that brachial plexus is really, it's not that complex, but if you know it, then you know it. If you don't know it, it's going to be hard figuring out the particular parts of it. So before we start brachial plexus, I'm gonna give you a personal recommendation that is that before you should know how to draw it basically. Okay, that's just a personal recommendation, but I would really advise you to know how to draw it. Why am I saying this? Because in the exam, in the OSPE, okay, you can't draw it, but for the MCQs I'm talking about right now, that just draw it on the that sheet they give you in which there's like your the password for the exam, the information, your name, blah, 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 and it has a white space. What I did in my exam, in my MSK, I just drew it. And it was really, really helpful for me in the MCQs because then I didn't need to recall, oh yeah, musculocutaneous was this. I just referred to the diagram and I went back, that's it. So now let's start with this. So let's start with, so first of all, we have 5 things, which are the roots, trunk, divisions, cords, and nerves. Okay, so those 5 things. And then we have these rami. So C5, C6, C7, C8, and T1. Okay, so now we have pairs, and C7 is the alone one, or you can say it's lonely. Okay, so it has no one to start this trunk with, it's just alone. So C5, C6 join together to form the superior trunk, which you can see here. This is a superior trunk formed by the C5, C6. C7, C8 form the inferior trunk, and C7 is just alone, it continues as the middle trunk. And then we have the cords. So the superior trunk runs to form the lateral cord. The inferior trunk runs to form the medial cord. Okay, so we have 2 cords, medial and lateral. Lateral is formed by superior, and also the addition of middle trunk. Okay, so middle joins together to form the lateral cord. Okay, and inferior is just by itself. Okay, inferior just forms the medial cord. And one more. Okay, yeah. So now the lateral and medial cords join together to give you this median nerve. Okay, so lateral cord gives a branch, which is the lateral root. Medial cord gives a branch, which is the medial root, and these two join together to form the median nerve. Rest nerves are musculocutaneous, which is just formed by the joining of the middle and the superior trunk forming the lateral cord. Lateral cord gives you the musculocutaneous. Ulnar is formed by the medial cord, which comes from the inferior division, inferior trunk. And then we have the posterior part of it. So posteriorly, we have the axillary and radial. So they come from the joining of superior, middle, and inferior trunk. Okay, so superior, middle, and inferior, these join together to form the posterior trunk. Now, we have an important nerve which has a really high clinical significance, and definitely you're going to get a question on this, is the that nerve is the long thoracic nerve. Now, it's formed by C5, C6, C7. It supplies the serratus anterior. Don't worry, it's going to come up later. And it leads to the injury, which is called winging of scapula. I'm pretty sure you've heard of it, and it's really important for both for your OSPE and for your MCQ. Definitely a question is going to come up on this. Okay, so long thoracic nerve formed by C5, C6, C7. Rest, we have gone through it, musculocutaneous, C5, C6, and the C7 also joins there, and to form the lateral cord. Median is from the lateral and medial cords, and the ulnar is just from the inferior trunk, medial cord. They continue as the ulnar nerve. So let's go forward. Okay, so this table has the injuries. I won't go through this, but you can read through this. This has the particular injuries. These are not relevant for your OSPE, I would say, but winging of scapula, definitely it's relevant for your OSPE. So please make sure to know this, that it's caused by the injury of long thoracic nerve. So let's move forward. So now the musculocutaneous nerve. Musculocutaneous nerve is, we have already established that it's formed by C5, C6, C7. Okay, and also the lateral cord of brachial plexus. Now, it's gonna supply your coracobrachialis and bicep brachii. Okay, and it also gives you the lateral cutaneous nerve of forearm. The important part here is the injuries. So we have like different joints which are involved here, and then the movement which are related to those joints. So first, let's start with shoulder joint. So if the muscular cutaneous is affected at the shoulder part, then it's going to lead to the weakened flexion, and also in the stability in abduction. Okay, so that would be lost. And then the elbow joint, that's going to lead you to severely weakened flexion of the arm. And then we have the, if it's on the radial ulnar part, then the supination would be affected. Okay. So obviously we're talking here about, if you're talking about the radial ulnar joint, then definitely we're talking about its cutaneous branch. It does not directly goes there. The cutaneous branch goes there. Okay. Then we have radial nerve, which we've established that it comes from C5, C6, sorry. Yeah, here. So C5, C6, C7, C8, T1, all joined together to give you the radial nerve and also axillary. The main thing about it is it's posteriorly. So these all would be the anterior, or basically like above. When you see the cadaver, you're gonna see that they're gonna be like a bit above the radial and axillary. Okay. So radial nerve, so C5, C6, C7, C8, and T1. And the muscles that it supply is the tricep, okay, the brachialis and the brachioradialis, and all the pretty much extensors of your forearm, because you know that it runs posteriorly. So it in the posterior compartment of the forearm are extensors. So we have one exception, which we will go through it later. But yeah, so it supplies the extensor basically. And now the injury which is clinically relevant for the radial nerve is the mid-shaft fracture of this humerus. Okay, so if we have a mid-shaft fracture of humerus, then radial nerve passes through it. We're going to do it. We have a separate slide for the fractures of humerus, but just to get an overview, so you would have radial nerve runs through the mid-shaft, and if it gets fractured, we would have this clinical presentation known as wrist drop. So basically, the person won't be able to extend the wrist, and yeah, that's pretty much it. So, okay, yeah, one more thing about the radial nerve, that it goes inside the anatomical sniff box. Okay, so the floor of the sniff box is sorry, the floor of the sniff box is formed by the scaffold. It's one of the scaphoid is one of the carpal bones, and there are three muscles that move the thumb. So we have the abductor pollicis longus, extensor pollicis longus, and extensor pollicis brevis. These all combine together to make the anatomical stomach box. This is not relevant to like OSPE, but the only clinical relevant part is the radial nerve, that it passes through it, and a fused fracture can also damage this. So yeah, and then we have, yeah, this is really important for your OSPE and for the MCQs. So this is the carpal tunnel syndrome. I'm pretty sure you've done it in the anatomy. So you know that there's a carpal tunnel, and along which passes the median nerve. And there could be any injury that would lead to the compression of median nerve. Now, if the median nerve is compressed, you would have the like, it can be basically caused by the narrowing of tunnel due to like changes in the osteoarthritic changes, or it could be a fluid buildup. Okay, that could lead to increased intracompartmental pressure. That could lead to the compression of median nerve. Now, the symptoms that the patient might present with would be the pain, numbness, and you guys, I'm pretty sure you guys know the since you guys know what like the median nerve supplies in the hand or the wrist, and the ulnar nerve what it supplies, the radial nerve what it supplies. You guys should know that up till which finger, or I think it's till the second, no, the third half, it's the medial nerve. The rest two are the ulnar nerve, and the dorsum is also supplied by the median and radial. It's you guys need to pay attention on that, but that's not relevant for OSPE, so we won't go there. Then we have carpal bones, which I'm pretty sure you guys know: trapezoid, trapezium, capitate, hamate. and we've already talked about scaphoid. Now, this Cooley structure is also known as dinner fork's deformity. It's just basically a clinical representation. That's why we call it dinner fork. So the thing is that the only important thing here is that radial striatal fracture. That's a clinical thing. I thought why not include it here because we were talking about the clinically relevant information. So the radial striate, it gets fractured. Again, it could be because of the outstretched extended hand. You fall on it, and this could get fractured. Or the scaphoid also can get fractured, which we're going to talk about it later when we're talking about the hand. Now, the important slide, which is again important for OSPE, is this. Okay, so now we have this humerus, and we know that. I'm sorry, I didn't show the slide. So humerus. So the thing is that here we have three nerves. No, four. Yeah, four nerves going through it, and we have few arteries. So let's start with the humerus. So you know that humerus has two necks. One is the anatomical, the other one is surgical. So around the surgical neck, so this part basically, okay. So the axillary nerve goes through it, okay, along with the posterior circumflex artery, okay. And if there's a fracture at surgical neck, axillary nerve is going to get affected along with this posterior circumflex artery. Now, if we have a mid-shaft fracture of the humerus, so we know that radial nerve learns of posterior part of it, so that's going to get injured along with the profunda brachial vein and artery. Then we have the supracondylar fracture that can lead to median nerve damage, and then we have this epicondyle. Let me mark it. Yeah, so this is the medial epicondyle, and if this is injured, the ulnar nerve goes behind it or posterior to it. Okay, so that's gonna get affected. So this slide is really important. Along with we have the long thoracic nerve, we have the supraspinatus. That's also important for your OSPE, and these carpal tunnel is again very important, and the humerus fractures. That's it. Now let's go to the hand. I think that's the last clinical slide basically, and then we're going to go to questions. So the hand, the two main concepts are that I'm pretty sure know the carpal bones. So the scaphoid, that's the most fractured bone, okay, and lunate is the most dislocated bone. So here we have the scaphoid. This one is scaphoid, okay. This is the most fractured bone, and lunate is the most dislocated bone. So that's pretty much it for the clinical relevant info for both OSPE and MCQs. I know this was meant to be an OSPE clinical or like particularly OSPE session, but I thought why not include few extra clinical details just to refresh your memory. So I hope you don't mind that. So now let's start with the question. So the way it's gonna go is that I'm gonna share the question, and then you are gonna solve the question by yourself because obviously this is not a live session. And then what we're gonna do is that you guys just pause the video because it's gonna be on YouTube. So you just pause the video, and once you're done with the question, just start playing, and I'll be discussing the answers. Okay. So let's start with the first question. So I want you guys to answer that what muscle is this? So the gray highlighted muscle. What's the action? And what's its nerve supply? So pause the video and okay. So now this muscle is the brachialis muscle. Okay. Now it's brachialis. That means that, and also you can see that it's in the anterior compartment. So that means its function is flexion. Okay, anterior compartment are usually all the muscles are flexion. Okay, and the nerve supply of it is the musculocutaneous nerve. Okay, so the important thing is that you identify the muscle, which is brachialis, what it does, the flexion, and particularly if you want to be like really particular, then you can say flexion at elbow joint, and the nerve supply of it is the musculocutaneous. And we have already done the root value of it. If they ask, maybe there's a fourth question in which they can ask you the root value for musculocutaneous or the chord. So that's the lateral chord, and it's the root value is what was it? C5, C6, C7. Yeah, C5, C6, C7. Okay, that's your root value. Okay, so next question. So first, let's do the upper question, and then we'll do the below one. Okay, so pause the video. Okay, so now what tissue is shown in the slide? So I hope you guys were able to answer this. This is the skeletal muscle, and the most key identification feature here are the striations. So uh, if you see striations, if you see something like this, that's pretty much skeletal muscle, because smooth muscles won't have striation. They will be, by the name, they will be smooth. Okay. Now, a characteristic of this tissue, they usually like to ask this kind of question, that like, how do you know that this is what you are saying it is? You know what I mean? So uh, how we can say that this is skeletal muscle? First of all, the thing I mentioned is the striations. Second of all, it is multinucleated. Okay, so you can see multinucleated cells. Third of all, the nuclei are at the peripheries. Okay, so they are peripheral nuclei. Okay, and now what under what control is this tissue? That's the voluntary control. Now, next question. So feel free to pause the video. Okay, so this tissue or gland, this is a gland basically. So this is the parathyroid gland. Okay, so part A, the answer is parathyroid gland. Part B, is it encapsulated? Yes, it is. Parathyroid gland is encapsulated by a capsule. Now, question C and D. So what are the cells in one and two? So let's zoom in. So one, this purplish, dark purplish cell, that's the chief cell, and the other one, which is like light purple, dark pink kind of, that's the occipital cell. Okay, so now occipital cell is just pretty much for just the support. Okay, and it's just a support cell. And the cell number one, which was the chief cell, it's really important for this gland, pretty much because it's the one which produces the hormone. So the hormone is the parathyroid hormone, and that's what the gland is responsible for. And the hormone does the calcium regulation, basically. Okay, so the important part was just to identify the skeletal muscle based on striations. You need to remember that skeletal muscle has striations and know how striations look like. So it's just these small lines which you can see. That's it. Okay. So moving on. Okay, so pause the video. Okay. Just 1 second. Okay. Okay. So the first image. Okay, let's do the first question. Okay, so the first image is the hyaline cartilage. Okay. Uh, the answer to the second question, what type of what is the characteristic type of this tissue? The main thing about it, it has the what do you call the perichondrium, okay, and also the chondrocytes, but perichondrium is the important part of it. And then where do you find this tissue? You find hyaline cartilage is in joint, trachea, or also I think the ribs also. Yeah, I think you do find it in the ribs. Yeah. And then the next question. So pause the video. Okay. So for this question, what type of tissue it is? It's again a cartilage, but this time it's a fibrocartilage or fibrocartilage. Now this image, the second one, the fibrocartilage, we the 15 batch got it in the OSPE. Okay, so you guys might be able to find it in the past papers. But so this picture is pretty much like, if you see this and you know what it is, class, you can answer it easily. So it's a really distinctive, unique image. Okay, so now what is the characteristic? That is the basically, first of all, it doesn't have the perichondrium. So that's the difference between hyaline and fibrocartilage. Fibro doesn't have the perichondrium, okay, and hyaline has it. Now the second thing is that chondrocytes are arranged in like, and parallel. Uh, how do I say this? Like parallelly, yeah, they're in parallelly, and in between those parallel sticks, you can say, or lines, there is this collagen fibers. That's it. Okay, so again, focus on this image. And also there's one more cartilage. I think I didn't add it here, but I can just mention that's the elastic cartilage. So you have three types of cartilages: hyaline, elastic, and fibrocartilage. The difference between hyaline and fibro is that you have perichondrium in hyaline, and in fibrocartilage you don't have it. And secondly, the obviously the visual feature. So this is really unique, the fibrocartilage. Okay, so pause the video. Okay. I'm sorry, I forgot one thing about this previous slide. Where do you find this tissue? I think I mentioned about the hyaline, but I didn't mention for the fibrocartilage. So hyaline, you find it in the joints, trachea, and ribs. Just make sure about the ribs, though. But for the fibrocartilage, it's pretty particular for the pubic symphysis. So that's in the lower limbs, in the hips, and the intervertebral discs. Okay, so these are the two places I think you can only find fibrocartilage. So pubic symphysis is important, and also intervertebral disc. And for hyaline, it's joints, trachea, and ribs. Okay, so now let's come to this question. Okay, so the first zone, A, is the zone of resorption. Okay, B is the zone of calcification. C is the zone of hypertrophy. D is the zone of proliferation, and E is the zone of reserve cartilage. So now these images are like, you just see them and learn what they are. But just to make a bit easy, you can, for E, for the zone of reserve cartilage, you can see the cells are not that proliferated as compared to D. And then the thing between D and C is that D, they're just proliferated, but in C, they're hypertrophy. So this is zone of hypertrophy. Okay, and B, you can see the hypertrophy, but you can also see this pink thing. Okay, and A is just more pink less hypertrophy cells. So that the main distinguishing is between C, D, and E. E is pretty like they're really less cells, not proliferative enough, and D is too much proliferation. C is hypertrophy. Okay. So yeah, for these two questions, I don't know if they're if they're OSPE relevant, but I found it in the OSPE drive, so I just added it for the sake of, just to refresh your memory. These are pretty much recall questions. So let's do them one by one. So pause the video. Okay. So what's another name for cortical bone? That's the compact bone. So choice B. And now for the next question. Okay, so for this next question, the answer would be again B, cancellous bone. So these two are really the recall questions. So there's nothing much OSPE relevant to explain here. So just know these two names. It might come up in an MCQ maybe. Okay, so these two are really important questions for your OSPE. So I'll give you some time to think about it. So pause the video for the first question first. Okay, so pause the video. Okay, so now, so A, name this one. This question is pretty obvious. That's the clavicle. Now, B, which one is the sternal end, and which and which one is the acromion end? So now, I told you guys the identification feature. So see, and at A, you can see this conoid process. Okay, so that's definitely A is the acromion, and B would be the sternal part of it. Okay, so the one which attaches to the sternum. Then C mentioned three ligaments that stabilize this bone. So that's pretty much your anatomy here. So we have three ligaments which are known as the costoclavicular, coracoclavicular ligament, and one more which attaches from the acromion. That's the acromioclavicular ligament. Okay, so three of them. Again, costoclavicular, coracoclavicular, and acromioclavicular. And then D, what pulls the clavicle upwards in case of clavicular fracture? I told you guys to do on the first slide. So that was the sternocleidomastoid muscle, And if the question was that what pulls it downwards, then the answer would be latissimus dorsi. Okay, so please remember this. One of them might come up. Okay, and yeah, so now let's answer the next question. So pause the video. Okay, so the bone, it's humerus, sorry, not humerus, and the common fractures of this bone structure. Okay, so the common fractures, we've talked about them. One is at the surgical neck, the other one is mid shaft, and the third one is supracondylar. Okay, sorry. Okay, uh, so the humerus fracture, the fractures are the surgical neck, supracondylar, and mid shaft fracture. So the the surgical neck, which structure is going to get affected? Axillary nerve. Which structure is going to get affected in the mid shaft fracture? That's radial nerve. Which structure is going to get affected in the supracondylar? That's the median nerve. Okay. Now, if I ask you the epicondyle, a medial epicondyle, particularly, which nerve passes through it? That's the ulnar nerve. And where is the medial epicondyle? That's the label point D, and A is just the head of humerus. Okay. So yeah, that's pretty much it for these two questions. So please pay attention to these two particular images and these two concepts, because they are really important for both your OSPE and for your MCQs. Okay, so now pause the video and answer this. Okay, so let's start with this question. Okay, sorry. Yeah. So this is anterior dislocation of the shoulder. As you can see, the head of humerus should be somewhere here, but it's really down. So yeah, this is the anterior dislocation. Now, I tried finding the posterior dislocation of shoulder, but I couldn't find it in the slides, but I'm pretty sure you have to know both of them. So please try to find its slides and share it with your batch. So yeah, let's get into this question. So the diagnosis is anterior shoulder dislocation, and now the structures which might get injured. So two of them, that would be the axillary nerve. Why? Because it goes to the surgical neck. Okay, and the muscle, there could be one muscle which is the bicep. Okay, so the long head of biceps to be particular, because that attaches hair. So long head of biceps, axillary nerve. If you want more, we could say about the subscapularis. The which subscapularis is the rotator cuff. Yeah, so rotator cuff, the subscapularis can also get affected. Okay, now moving on. Pause the video. Okay, so this is the clavicle and the structures attached to it. So let's start it one by one. So A is the clavicle. B would be the acromion process, which attaches to the acromial end of the clavicle. C is the humerus. D is the surgical neck of the humerus. So the axillary nerve goes around it, along with the posterior circumflex artery. E would be the glenoid fossa. I'm not sure if it's clinically relevant, but this is glenoid fossa. F is coracoid process. So I think the most important structure, definitely it's A. You need to identify it. B, and for C, if you need to be particular, this part of the humerus is known as the greater tubercle. So yeah, if you want to be particular, that would be the greater tubercle. D would be the surgical neck. E is the glenoid fossa, and F is the coracoid process. Now, three muscles that attach to the structure labeled C. Okay, so the three muscles are, so the muscle that attach at the greater tubercle would be the rotator cuff, basically. So the supraspinatus, infraspinatus, and the third one would be the teres minor. Okay, so yeah, next question. Okay, so pause the video. Okay, so let's get into this question. Sorry. Yeah. Okay. So Name the muscle label A and B. So A would be the deltoid. I hope you got it right. And B would be the pectoralis major. Okay, pec major. Now, a test to know that if A is working. So the test would be the if you like you ask the patient to like you basically you do this first. So you pull their arm horizontally, so basically away from their body. Okay, to see whether it stays there or it falls down. So if it stays there, that means that the deltoid is working. But if it falls down, if the arm doesn't stay there, it just goes down. If it drops, then the muscle is not working. Then we have the sorry, we have the question C, which is the what is the role of muscle B? So muscle B is what? Pec major. So pec major would be the adduction, so a deduction. So it of the arm basically. So it's gonna keep your arm towards your body. So you can't. So basically, it's just for towards your body. So a abduction is away from your body. A deduction, adduction is for keeping it towards your body. Okay, and what muscle lies underneath muscle B? So muscle B is pec major, so below it would be the pec minor. Okay, now please feel free to pause the video. Okay, so this is a really important question for SOSP, really important. So now the first thing I this here it's identified, but so the thing is that whenever you see this brachial plexus, the first thing I would say you do is on a cadaver. So you do is that you make this M. You identify this M basically. Okay. So the M which is here. So this. Okay. It's really gonna help you to identify the nerves, the cords, and yeah. Okay. So each of these terms. Okay. So so the lateral would be this one. Okay, so this is the lateral. Okay, and what it is the musculocutaneous nerve. Okay, so this is the lateral strand which I've circled. That's the musculocutaneous. Now the mid part of this M, that's the median nerve. Okay, remember we said that lateral cord and the medial cord. No, not the medial. Oh, sorry, the inferior. Yeah. Okay. Yeah, the middle cord. Yeah, basically. So middle cord and the lateral cord join together to give you the median nerve. Okay. Then the most medial structure here, this one. Okay. That's what. That's your ulnar nerve. Okay. So this is really important to know how to identify this. So the first important part is to identify the M, find the M. Then I'm pretty sure it's going to be easier for you to identify the structures. Let's move on. Okay. So now name the pin structure. So basically this colored one, the red color, and its nerve supply, and what movement does it perform. So pause the video. Okay, so the pin structure is the teres major. Okay, and the nerve supply to it is the lower subscapular nerve. Okay, so teres major, the nerve supply is lower subscapular. What movement does it does? It medially rotates your arm, and it also adducts your arm, just like deltoid. Okay, so it adducts your arm, adducts your arm, so keeps your arm towards your body, and it also medially rotates it. Okay, moving on. Pause the video. Okay, so this is a really important image. Why? You're gonna know it. Now, that's because I remember I told you about the long thoracic nerve. So here it is. So this nerve is the long thoracic nerve, and the muscle it supplies, we know it's the serratus anterior. And what's the function? It is for the winging of scapula. That's a clinical condition. My bad. Yeah. So serratus anterior, the clinical condition is that it leads to the winging of scapula. Okay. So please keep this image in mind, keep this nerve in your mind, and the function of the nerve and the clinical condition. Okay. So pause the video. So let's start. I'm sorry, I didn't show you the why it's stuck. Sorry. Okay, yeah, so pause the video. Okay, so Identify the structures like A, B, C, D. Okay. So first, let's identify the most important thing in this image, which is M. So here it is. Here's the Mercedes, whatever you want to call it, sign. Okay. So here it is. Here's your M now. Now, this time, this side is medial. Okay. This circle is now the medial part. So that would be the ulnar area. Now, let's start with A. So A is the lateral. Take it back. That's the lateral cord. Okay. Which is going to give you this, the musculocutaneous nerve. Okay. So A would be the lateral cord. B would be the median nerve. So this, let me change the color so it's better visible. Let's do blue. Okay, so yeah, so this is the median nerve. Okay, so this was the lateral cord. Okay, A was the lateral cord. Sorry, this circle would be the ulnar area, and B is the median nerve. And then C would be the axillary artery. Okay, C is the axillary artery, and D is the radial nerve. Remember, I told you radial nerve and axillary nerve are a bit posterior. As you can see here, it's a bit below the whole brachial plexus, basically. So it's a bit under the thing. So C is the radial nerve. D is the radial nerve, my bad. And C is the axillary artery. B is the median nerve, and A is the lateral cord of the brachial plexus. Okay, next question. Okay, so structure E, I'm pretty sure you guys know this. This is brachioradialis. Okay, the function of it, it flex the arm, and the nerve supply is the radial nerve, basically. Now, the other four muscles which are coming, these I would talk about. These, let me change the color now. Okay. Oh, yeah. So these muscles basically are over your cubital fossa. So these are clinically relevant for your MCQ. So please pay attention on these. Okay. So let's move forward. We answered this, right? Yeah. Okay. So pause the video. Okay, so again, so most important part, as soon as you see this, you have to find the M. Okay, yeah, so the M is this. Okay, our Mercedes sign is here. Now, so it's saying name the structure pointed by the arrow. So arrow continues here. So that's definitely the ulnar nerve. Okay, because it's medially towards the body. It's not laterally. Okay, so this is lateral, and this is medial. Okay, now name the two muscles it supplies. And so the two muscles which are supplied by the ulnar nerve would be, there are many, but okay, let's start with flexor carpal nares. There could be your dorsal introsseous muscles, which are responsible for your abduction of the fingers. It could be the palmar introsseous muscles, which are for your palmar adduction. Okay, the third and fourth lumbrical, that's really important, that it supplies, and the hypothenar muscles, that's important for your opponent's rigidity minimi. And also they supply the, yeah, that's pretty much it, I think. So hypothenar, third, fourth lumbricals, and the flexor carpal nares. I think these three are the important ones. So that's it for this question. Let's move on. Okay, so pause the video. Okay, so this picture is important. I don't know if you get the same picture or not, but that's what I found regarding this topic. So this is the median nerve. This nerve is the median nerve. Okay, and we've talked about it. That's clinically important in a syndrome, which is the carpal tunnel syndrome. Now, name two sites where the structure can be injured. So the two sides will be the first of all, that would be the condylar area of the humerus. So that part, and the second area would be the carpal tunnel itself, basically. So there could be a fluid buildup. Okay, that could lead to compression, or the basically compression because of the intracompartmental pressure that's going to get increased. So it's going to cause compression of the median nerve, or it could be a fracture of the supracondylar area of the humerus. Now, name a clinical condition, clinical syndrome associated with this. We have already mentioned that's the carpal tunnel syndrome. So let's move forward. Okay. Now name. Okay, first pause the video. Okay, so name the muscle that's shaded green. This is, again, we have done this question. I think pretty much that was on the model though. This is the brachioradialis. Oh yeah, I forgot to mention one thing about brachioradialis. Yeah, it's supplied by the radial nerve, right? So that means it's in the posterior compartment, or at least it starts from the posterior compartment. And you know that posterior compartment has the extensors of the forearm. But now I mentioned last when we discussed this muscle on the previous question, I said that it's a flexor. It is a flexor, but this is the unique thing about it. It's in the posterior compartment. It is supplied by the radial nerve, but still it is a flexor. It is a flexor of the forearm. It's not an extensor. It's a flexor. Okay, so that's important. That just keep that in mind. Okay, now where it is located, that's the posterior aspect of the forearm. And what's the action? I just said that it's the flexor of the forearm. Okay, now pause the video. Okay, so name the movements A, B, C. So A would be the abduction. Okay, so now to demonstrate it, it's gonna be like you have to basically move your thumb away. That's pretty much it. Move your thumb away. That's abduction. If you bring your thumb towards your palm, that's gonna be flexion. Okay, so B is what? Flexion. And C is the opposition. Now the joints involved, if you want to be specific, the joints involved in A, that would be the carpometacarpal. Basically, all of them, the same joints involved. So in A, the abduction is at carpometacarpal joint of the first digit, so the thumb. And then in B, in the flexion is at carpometacarpal joint of the thumb, and opposition is at the carpometacarpal joint again of the thumb of the first digit. Now, which muscle is responsible for the movement in C? So C is opposition. So it's the opponent's pollicis, and because it's of the thumb, it's supplied by the median nerve. But we have also opponent's pollicis of digiti minimi. That would be supplied by the ulnar nerve. So keep that in mind. Okay. Yeah, I think that's pretty much it for this. Yep. Okay, let's move on. Pause the video. Okay, so name the muscle label A, and whose function is, oh, they gave you the function. Whose function, I should have removed this though. Whose function is adduction and medial rotation of the arm. So now it should be pretty much easy because now you know the function. So that the muscle is subscapularis. Okay. B, name two muscles found on the opposite side of the muscle A. Okay, so opposite side of A basically. So the other way around. What muscle would be there? Supraspinatus and infraspinatus. So you know that one side of the scapula, it has the subscapularis. On the other side, above it's supraspinatus, and the below supraspinatus we have infraspinatus. Okay. Then which nerve, if blocked, will restrict the abduction of the arm above 15 degrees? Okay, so we talked about the lower 15 degrees, or like the first 15 degrees. Okay, so that was for supraspinatus. Now the muscle they are talking about right now is the deltoid, and deltoid is supplied by the axillary nerve. Okay, so if axillary nerve is blocked, deltoid won't function, and you won't be able to abduct your arm after 15 degrees. You would be able to initiate the abduction, but you won't be able to move it past the initiation phase. Okay, let's move on. Now, pause the video. Okay, so the first question, name the muscles label A and B and list the main function of A. So A would be the pec minor, and you can see the pec major. So basically, I remember there was a question which showed you the pec major, and they asked you what was below it, right? Let's see, where was it? You know what? Keep. Okay, so let's see where was the question. Yeah, here. So you can see they asked you what muscle lies underneath. So now in this question, what they did is that they cut maybe this part, okay, and just I don't know if it's not enough. Oh yeah, okay. So basically they cut this part and they just flipped it. Okay, so now you see the pec major. Okay, let me go here. Yeah. So now you see the pec minor. Okay. So A would be the pec minor and B would be the coracobrachialis. Now, see, B is going towards the humerus, towards the biceps. So that's coracobrachialis. Okay. And now list the main function of A. So A is pec minor. So it's a function of pec minor. That's basically just to stabilize the scapula. So what it does, it takes the capilla, or it draws the capilla inferiorly and anteriorly. So basically it depresses the scapula. It brings it down. It brings it lower. Okay. Now what movements will be restricted if pec major is damaged? So if pec major is damaged, you won't be able to do the adduction. So we've talked about this earlier. So you won't be able to move your arm closer to your body, and also the medial rotation of humerus. So you won't be able to do adduction and medial rotation of humerus. So yeah, that's it for this question. Oh yeah, we're done. Okay, so that's pretty much it about the upper limb aspect of it. Okay, now Samra is inshallah gonna tell you about or teach you about the lower limb.
Assalamu alaikum, everyone. My name is Samra Mirza, and I'm a second-year medical student. Today I'll be covering the second part of the OSPE review, so that'll include some of the remaining of anatomy, so that's the lower limb, and a little bit of history revision. These are my contact details as always, so feel free to contact me if you have any questions, and we can begin, I guess. So again, this is just an overview. We'll start with histology. So histology is very, very easy when it comes to the OSPE, especially for like muscles and Dr. Hyde's questions. They're very, very simple. So here you can see these are the pictures that he's given of skeletal muscle. They obviously have some characteristic features that you need to know just in case they ask you. So they'll say, identify this, identify the structure, and then they'll say, give two characteristics that help you differentiate it from other things. And so we'll get into it. So starting with, first thing you can see, obviously we have the striations on the muscle. You can see them here. Then we obviously have, the second thing that's always focused on is these. So the nuclei are in the periphery of the cells instead of like in the center of them. So if they, like the two main characteristics that you would always give for this is the structure has striations and that the nuclei are in the periphery. Additional features could include obviously the A bands and the I bands. You can see them briefly here. The lighter and the lighter versions and the darker ones. So you can state them, but again, the main focus is usually on the nuclei and the periphery and the striations. This is again another picture of it. Again, nuclei are somewhat in the periphery. Obviously, with the cuts, it varies, but that's a characteristic feature. Sometimes you might be given the transverse section and it can confuse people. So just the pictures here just to like acquaint you with it. Again, here it's very clear that the nuclei are in the periphery. And in this case, obviously you cannot see striations. But what you can see is like the endomysium, the perimysium, and so on and so forth. So like so this would be like the endomysium. Here around it, like around one big thing, you would have the perimysium and then so on and so forth. These are just the basic structures that you have. And so histology is always structure, function, location. So the like structure would be the histological features. Again, muscle striations and nuclei in the periphery. That's the first two, and then obviously have the bands and the lines. Then you might have additional features, the ones I showed, endomysium and perimysium. Function, usually for skeletal muscle, I wouldn't think you would ask it. And lastly, then just identify what it is, and it's a skeletal muscle. Then we move on to cartilage. Now you have three types. You have hyaline, you have fibrocartilage, and you have elastic cartilage. So we'll go through them one by one. So hyaline cartilage is very recognizable, and I'm sure everyone thinks that too. So we'll just break down some features that we need to know. So we have chondroblasts and we have chondrocytes. So chondroblasts are more in the periphery. You'll see them here and you'll see them here. So they're more towards the peripheral ends. And then you have the chondrocytes. And chondrocytes have the feature that obviously they're near the lacunae, and the lacunae, they're inside them as well. So chondrocytes and lacunae go hand in hand. So that's how you can differentiate them from chondroblasts. And the next thing you should know is from these slides that the hyaline cartilage has two layers. It has a fibro layer and it has a cellular layer. So this is perichondrium cellular layer, the one I've circled here. So it's this entire section. And then you have the perichondrial fibril layer, which is this entire section. I hope that part is clear. Again, same thing here again. Fibril layer of the perichondrium and then the cellular layer. Again, these are just the same things that I covered. Again, you see the purple color and you see this appearance. You can easily tell that it's hyaline cartilage. Moving on, we come to elastic cartilage. Usually, it is also pretty distinguishable because of the special stain. So hopefully this would be easy for you guys as well. It also has the two layers. It has the fibril layer and the cellular layer. And then here you have the chondrocytes again on the inside. An important thing to note would be that the fibril layer is the outer one and the cellular layer is the more inner one. And same thing. And then we move forward to the last cartilage. Sorry. Um, we move to the last cartilage, which is the fibrocartilage. So the first thing you need to know is that the fibrocartilage has like a thick row of collagen, and it's like neatly stacked collagen, and they're all packed together. So this pink stuff is representing that. And then you have even the rest of the cells, they're all arranged pretty neatly in like rows and layers. And so you have chondrocytes and you have chondrocytes inside of lacunae, and that's it. Again, you have a fibril layer and I guess a cellular layer as well. That's it. And that covers cartilage for us. Then we move on to bone. Again, I'm just covering very, very basic features, right? So if we come to bone, you'll have lamellae. Now, lamellae is just like it's like things that are arranged, and they can be it's like layers which can be arranged either circularly or in rows. So here, like this entire thing, it's a lamellae, and it's like a circularly or concentrically arranged lamellae. And then you have this, um, I hope you can see this thing that's covered with red, or even here, these are the parallel sheets, again, of lamellae, and they're arranged like this. Then you have these are the darker parts in the center of the concentric lamellae. These are the central canals, also known as Haversian canals, and they contain blood vessels, small blood vessels, so that's their importance. You also have Volkmann's canal here, and again, a very characteristic appearance. And so like if they point at it and they say what it is a Volkmann's canal. That pretty much covers it. And if they ask you what this is, like the type of bone, because obviously they can show you different types of bones, this is a lamellar bone. So this is important. Like this can easily be a question. It's easy to solve. So lamellar bone, remember that. Moving forward, we're still at bone, but we're now at a different type of bone. As the T may suggest, this is trabecular bone. So if they ask you characteristic features, you have two. You have the trabecules, which are these. So just like these cavities, I guess I could say. And in the center of them, you have the bone marrow. So that's what BM stands for. Most definitely won't be labeled on the actual exam, but you'll be able to tell. Yeah, and so these are the bone marrow cavities, and again, pretty simple, very basic characteristic features. These again don't really have much of a function question, but they do have a structure and location question. So location question be what this is, trabecular bone, histological features, trabeculate, and bone marrow. Lastly, we come on to this slide, which is mostly to show you like the separate cells of the bones. So you have osteoblasts, osteocytes, and osteoclasts. So starting with osteoblasts, there are these ones. They haven't been fully, I guess, developed, so you can see that they are irregularly shaped and they have like a variety of sizes. They're still developing and they are on the periphery. They're not inside in the main part of the bone. Then you have these, which are osteocytes, and their characteristic feature, they are inside the lacunae. So osteocytes are almost always inside the lacunae, and they all look identical. Like it's pretty basic, I guess, structure of them. Then you have osteoclasts, which are also in the periphery, but they don't look like osteoblasts in the sense that they do look developed and they do have their own like feature, which is that they're very, very large and they sit right at the periphery, and they don't like here you can see that they're branching off, they're forming like little tops, I guess. But here it's a very specific feature, and usually if you zoom in, you can see like sometimes that it's like attaching like this to them. But again, it probably won't be able to see it that way in the OSPE, so just learn it like this. On the periphery, you can either have osteoblasts or osteoclasts, depending on their appearance. Either they're regularly shaped and they're not too many and they're large, so they're osteoclasts, or they're irregularly shaped and they have like a variety. So they're usually osteoblasts and they're larger in number, as you can see. And then you have osteocytes in the center with the rest of the pink stuff, and they're inside lacunae. I hope that part is clear. Again, this is another picture of it. So you can see the osteoblasts, they're much larger in number and they're surrounding it. And then you have the osteoclasts, which are all in the lacunae. And I don't think osteoclasts were visible in that slide. So this is just bone. It's not specified. Now this slide, for us, when we were learning it, it was heavily stressed upon. It can have very, very simple questions. They could just ask you to identify what zone it is. So we have 5 zones here, and these are essentially showing like the ossification process. So you have 5 zones here, and they might ask you what zone it is and like give a characteristic feature of this zone. So we'll go by one. So the first zone is this one, and this is reserve cartilage. And so these descriptions are from his slide notes. So if they ask you what are characteristic features of the reserve cartilage, no cellular proliferation or no active matrix production. Then you have 2, which is the proliferation zone. So here, his explanation was that these cells look larger than those in the reserve zone, which is true. They both are inside lacunae, like even here and here, but these cells in 2 obviously look much larger as compared to 1. So now we're at proliferation zone and we're done. Then we move on to the 3rd zone, which is the hypertrophy zone. So these are zones of reserve cartilage, zones of proliferation, zones of hypertrophy. That's the full name. So here are the things you would look for: clear cytoplasm, active chondrocytes, which are secreting collagen type 1, and we'll see them. And you have linear bands between the columns of cartilage cells. So let's go look for these. So this pink stuff around them, these are the cartilage that they're releasing, right? And they obviously look active, and there's like clear bands between the rows of cells as they're secreting cartilage. I hope that makes sense. Zones, this is again zone of hypertrophy. For these questions, if you don't want to understand them, you can just memorize the picture and memorize like one characteristic feature even. Then we move on to zone of calcified cartilage. So you'll just say that here the matrix is calcified. So if we move back, this is zone of calcified cartilage, and you can see it here. And you can also see it inside the cells themselves. They're calcified. They're starting to become calcified, but this is obviously the main part, which is the calcified cartilage. And so this is a zone of calcified cartilage. And then the last zone is zone of ossification. So this is the major part. Majority of the cartilage has been calcified here, and obviously the cells have increased cartilage in the center as well. Osteoblasts in this area are in a they're settled in a layer over the calcified cartilage. So they're not completely clear here, but I would say they're at some point maybe either between these or between these. Dr. Shahid would have explained it better than me. All you need to focus on are again just the names where they match. So 1, 2, 3, and 4 and 5. You just need to know what they are. It could be an easy identification question, and you need to know like a characteristic feature. Then we come on to skin. So skin can be annoying, and I don't really have any tips for it, to be fair, but we'll try to like go by it step by step. So it has a bunch of stratums, and they all have some features that you need to know, but we'll try to go over them quickly. So this one here, this is obviously like a layer of keratin, I think, and these have these stratum layers inside them. And then here's when the epithelium is starting. So we'll go by one by one. This is again another picture so you can see it. So let's go by one. So first you have stratum basale. Stratum basale is the one right here, right? And this one, it has a characteristic feature of containing melanocytes. In this image particularly, they're not pointed out, but you need to know in general that stratum basale contain the melanocytes. Then you have stratum spinosum, and these are known to contain Langerhans cells. So even if you can't see them on the slide, if they do come in the exam, if they ask characteristic features or what they contain, just like memorizing these small details can save you time for sure. So we are at stratum spinosum, and they contain Langerhans cells. Stratum spinosum is this area here. So stratum basale was the light pink area that you can see, and it's circled here. And then stratum spinosum is like the purple area or like slightly magenta-ish area surrounding it. So stratum spinosum, also done. Then you have stratum granulosum. So these contain flattened keratinocytes. Stratum granulosum is right here. So it's pointing at like this darker patch. I'm sorry, the red doesn't really help, but essentially this darker patch of cells, like this outline that I'm following, this is the stratum granulosum, and these contain the flattened keratinocytes. Then on top of it, you have stratum lucidum, which is like right on top of stratum, what's it called? Stratum granulosum. Stratum lucidum does have a specific, what's it called? Feature, which is that it's only found in like thick skin areas. So like your palm or the plantar surface of your foot. These are usually found there. So that's a characteristic feature, and they contain dead keratinocytes. So again, stratum lucidum isn't available in every like type of skin. Lastly, you have stratum corneum, which it doesn't really have characteristic features. It's just the top part of the keratin or the body of it. So, these are the histological features. Again, memorization helps. Try to know them in order. So you start with basale near the basement membrane, not completely, but like somewhat near it. So basale, then spinosum, surrounding the basale, then granulosum, which is the flattened bed, so like thick purple, dark purple outline that we showed here. But this one, the one that I outlined here. That's stratum granulosum. Stratum lucidum is not available in every area, and then stratum corneum. That covers skin. Then we come on to parathyroid gland. So here, your two main important parts are obviously the chief cells and the oxyphil cells. So here you have your chief cells and your oxyphil cells, and they've been marked as 1 and 2, respectively. And then you also have adipocytes. So again, this is a very classic feature of your what's it called, parathyroid gland. And yeah, they might just point at the labeling, and they'll ask you which one, what is 1 and what is 2. You say chief cell, oxyphil cells, and they might ask you like a function of them. So the main function is secreting PTH, and then bone resorption is like a secondary function. But this is your main thing, secretion of PTH. And then now these are just some questions. These are from the mock exam, by the way. So you can either refer to those or you can do them here. They're not all of them, there's just a few of them just for the sake of practice. So you can pause the video for like a good 1 minute or whatever time you need, and then we'll move on one by one. So for this question, this is something that we just did. So this is the skeletal muscle. Obviously, we have our striations and nuclei in the periphery. So those are the histological features, and it is skeletal muscle. Next question is this. You can pause, and I'm going to move forward. Obviously, hyaline cartilage, without a doubt. So now you have the hyaline cartilage, the purple, easy, that's first identification, and then they want the labeling of the structure labeled as A. So remember that I mentioned there's a cellular layer and a fibrous layer of the perichondrium surrounding the cartilage. That's A, so that's what A is. In general, it's the perichondrium. Now, you can't differentiate between the two layers in this specific image. These are not the ones from Dr. Shahid. You have a fibrous layer and a cellular layer. Next question is this. It's for skin. Moving on. So obviously they want you to label it. So X was stratum corneum, as you mentioned, which is the main body of the keratin layer over the skin. And then Y is stratum granulosum. And then Y is stratum granulosum. And then here they're saying where is this specific type of lining found? So remember that this contains this specific image contains stratum lucidum, which we've shown here. So if I go back actually. Stratum lucidum isn't something that's been marked on the image, but it is shown to be here. Remember, this is what stratum lucidum is. It's like lying right over the stratum granulosum, and it's this thicker layer over here. All right, and so stratum granulosum is present here. It contains the dead keratinocytes. So in this image shown in the question, um, just know that this image with this thick layer, this immensely thick layer of keratin, it contains stratum lucidum. And so this type of lining is found in the palms of the hand and the soles of the feet. Yeah. Y is stratum granulosum. Again, granulosum, the really thick like outline over the epithelium. And X stratum corneum is just the main body of the keratin layer. With that, we have completely revised histo. I would just recommend skimming quickly over your slides and maybe even printing them out if you're going to have a long wait time in PHA. So next, we're going to move on to the anatomy of the lower limb. So I'm starting with the gluteal compartment just because it's a bit more simpler than the rest of the stuff. In my opinion, the main points of focus for the gluteal compartment are obviously the muscles. So you have to know gluteus maximus, medius, and minimus. And you need to see what they look like. So look at the fan shape of the gluteus minimus and note that gluteus maximus is more on the outer aspect and medius sits in the middle. And you need to know their nerve innervations, and you also need to know the clinical associated with it. So gluteus maximus is supplied by the inferior gluteal nerve, which is coming from the greater sciatic foramen. I would suggest memorizing their origins, their nerve roots, but that should just be part of your general content outside of OSPE as well, so I'm not mentioning it here. Gluteus medius and gluteus minimus are both supplied by the superior gluteal nerve. Note that for Trendelenburg sign, you would see a gluteal nerve injury, which is a superior gluteal nerve injury, which would show problems with gluteus medius, showing a positive Trendelenburg sign, which is like a hip drop on the opposite side from the damage. So if the nerve problem is on the right, the hip drop is being seen on the left side. Yeah. Well, that's mostly all you need to know for gluteal compartment. We'll come to questions for it. And then we move on to the hip joint. So when it comes to joints, the important parts are obviously the type of joint. So people usually end up skimming over those and they're free marks if you don't know the answer. So you're losing them. So first thing, very easy, it's a ball and socket type of joint. And so this is a ball and the socket is here, and you have the acetabulum, which is where this ball is resting. It's already pretty deep as compared to the shoulder joint, but you also need to make it deeper just to stabilize the joint. So you have the acetabular labrum, which is a type of ligament going around this acetabulum. You also have more ligaments. You have ligament of head of femur, and we'll come into them right here. So the names of the ligament explain where the ligaments are going. So if you have an iliofemoral ligament, which has been cut to show the underlying structures, it goes from the ilial part of the hip to the it's called the femur part of the bone, the femur bone, sorry. And they attach like near the greater trochanter and as well as a bit over the lesser trochanter. That's one ligament, iliofemoral ligament. Then you also have the one second, I'll come here and show you exactly what I mean. You have the iliofemoral ligament. It is, oh, you need to definitely know this. It's the strongest ligament in the body. It's very, very important. It prevents hyperextension. So this is a pretty important function that could be hinted at or could be asked about or it couldn't be. It just depends on them. But iliofemoral ligament, strongest, prevents hyperextension. You have a pubofemoral ligament. As it's being suggested, it's from the pubic part of the hip bone and it's going to the femur. So this is the pubofemoral ligament right here. Then you have the ischiofemoral ligament. Again, as the name suggests, from the ischium to the femur. I think in this image it has been cut, so we'll just move on further. For ischiofemoral ligament, it's limiting internal rotation. But I guess the more clinical part would be it's stabilizing the joint in the standing position. Then you have ligamentum teres, or ligament of head of femur, which is the one that was shown here. It's also somewhat fan-shaped, and it's within the acetabular area, so it's like right next to the acetabular labrum. And the important part here is that it carries a small artery, which is the acetabular branch of obturator artery. This is an important thing, and you should definitely know this. Whether for your OSPEs or your MCQs, depends on the doctor. And again, acetabular labrum, we already discussed it. Again, focus on acetabular branch of obturator artery, which is moving with the ligamentum teres of the femur. With that, we cover the joint. There's not much to it in my opinion. Obviously, they might show x-rays and they might show fractures, and we'll come to those as well, so don't worry about it. So for the thigh muscles, I'm sure you guys learned it with one of the doctors, but you divide the thigh into its like compartments. Obviously not like this, but essentially you have an anterior compartment, you have a medial compartment, and you have a posterior compartment. And these help you in determining function. So medial compartment for the thigh they're usually adductors. Posterior compartment are usually hip extensors or knee flexors, and anterior compartment is usually hip flexors and knee extensors mostly, but there's also rotation involved. You would know this best. These are pictures of it. We'll go by one. So again, anterior thigh is hip flexion and knee extension. So first we'll have the quadriceps femoris and the sartorius. So let's come here. Quadriceps femoris, as the name suggests, is made of 4 muscles. So you have the sartorius, which is this long sling-like muscle. It starts laterally and it moves to the medial end. Then you have vastus lateralis, medialis, and once you remove rectus femoris, you'll be able to see vastus intermedius. So, okay, we'll go by one. This is one muscle of the quadriceps femoris, which is rectus femoris. So it's this one. Its tendon is contributing to the patellar tendon. Then you have vastus lateralis. As the name suggests, it's on the lateral side. And then you have vastus medialis, more on the medial side. And then again, once you retract rectus femoris, you'll be able to see vastus intermedius. For these anterior compartment, their major nerve supply is the femoral nerve. Generally, this is what you need to know. Then we move on to the medial part. So this is the part that covers the medial, and this covers posterior. So if we come to medial, the medial does have a bunch, but it's okay, we'll come to them. So for starting with medial thigh, as I mentioned, they're hip adduction. You have 3 adductors. So longus, brevis, as the name suggests, and adductor magnus. Adductor magnus has 2 parts. It has an obturator part and it has a hamstring part, and we'll come to that as well. And it has gracilis, pectinis, and obturator externus. Let's come and see them on the diagram. So pectineus muscle shown here, it's definitely been cut, but it would be attaching somewhere here, and it's like the first muscle you would see, I guess, if we're starting from like before the pubis, and it's like this. Then you have then if you remove the pectineus muscle under it, you would have obturator externus. So it's right here. It's right under pectineus. Then you have the adductors. So adductor brevis comes first, and then right after you have adductor longus. Then you have adductor magnus. Now, adductor magnus has 2 parts, as I mentioned. It has an adductor part and a hamstring part. So the adductor part is the obturator part is the one that contributes to the medial thigh, while the hamstring part is what contributes to the posterior thigh. And yeah, okay, so we'll come here now. Yeah, I think that covers most of the muscles here, and for them, the nerve supply is the obturator nerve, except for a pectineus muscle, which also receives a supply from the femoral nerve. And that's mostly just because of location, because it is like overlapping with the same area as the femoral nerve supplied muscles. So that's medial thigh done. And then we have the posterior thigh, which is hamstrings, and that's it. So let's come here. So for hamstrings, you have I hope this is the posterior thigh. Yeah, this is the posterior thigh. So you have hamstrings and you also, oh, sorry, I forgot to cover an important muscle, the gracilis, which is from the medial thigh. It wasn't shown in the other picture. So the gracilis is completely on the medial aspect. You can even see it from the anterior thigh sometimes. Okay, this one right here is the gracilis muscle. It's like very much on the medial aspect. So it's also long. It looks pretty long, and could sometimes people confuse it with sartorius, even though sartorius is a sling and it's coming from lateral to medial, and gracilis is completely medial and it's long and it's like attaching from like somewhat of the pubic area directly to the medial part of the knee joint. So yeah, gracilis covered. Now we'll come to the hamstrings, biceps, semitendinous, and semimembranous. You might have seen them in lab. Semimembranous and semitendinous, the names are given because of the appearance of the muscle. One muscle could be somewhat thin and it looks like a tendon, and one muscle looks like a membrane because it's flatter. So if we're looking at this thigh posteriorly, this is the medial aspect and this is the lateral aspect. So semitendinous is, or semimembranous is more medial as compared to semitendinosus. I hope that makes sense. Yeah, there's no other way to put it. Semimembranous is more medial as compared to semitendinosus. Or semitendinosus, you could say, comes first if we're talking laterally, and then semimembranosus comes next. You guys might have a better way of memorizing it. Those are just how I used to study them. And then you also have biceps femoris, which is obviously this one right here. This one right here. It has its two heads. As you know, be sure to write biceps femoris completely. These are free marks that can end up being lost sometimes. The second head of biceps femoris is a little under it, I think, and it's pretty short. The rest of the muscles here, you can have a look at the gluteal compartment again. Gluteus medius, gluteus minimus under it, and it's lying over it, and then gluteus maximus, which is like the final outermost muscle. But that's mostly it for this. As for the nerve supply, it's supplied by the sciatic nerve and then the tibular and common fibular as well, which are the branches of the sciatic nerve later on. That's mostly it. Again, in the exams, you usually you might get cadaver pictures, or you might just get like a model of the cadaver, or wait, sorry, let me rephrase that. You might get model pictures, or you might get the cadaver, and they might just point to the muscles there. For cadavers, I would recommend if you have time to just quickly go over Dr. Atif's, YouTube channel where he's showing the muscles. You don't even have to watch the whole video, just like quickly skim to the points where you can see the muscles labeled. Because I think that's the best way to find cadaver pictures, or go over your lab committee pictures. These ones here are just to orient you to the general idea of what you're expected to see. And yeah, that's mostly what I can say about the thigh muscles. And then we come to the vessels, or before the vessels, the femoral triangle, which is obviously this. You need to know its boundaries. Obviously, know superiorly it's being made by the inguinal ligament. Laterally, it has the sartorius muscle bordering it, and medially, it's partly gracilis, and I guess another muscle here too. Again, you just need to memorize the boundaries. More important than the boundaries, though, are the contents. Medial to lateral, like this way, you would say van. So you have vein, artery, and then nerve, and obviously lymphatic tissue after nerve. But that's the main thing. So this is your femoral nerve. This is your femoral vein, and this is your femoral artery. Oh, sorry. Moving on to just some arteries of the thigh. So obviously the main one supplying it is the femoral artery, which is a branch of external, or which is a continuation of external iliac artery. It obviously gives off its branches. So it has the medial circumflex femoral artery, which is very important clinically, especially in cases of fractures, because it's wrapping around from this way. It's wrapping around the neck of the femur. And so in cases of fractures of the neck of the femur, this artery is at risk. And this is something that Dr. Atif has stressed upon in lab. You also have the lateral circumflex artery, but the one more at risk is the medial. You also have profunda femoris artery, which are just branches that are slowly wrapping around here. And then the femoral artery ends up passing through the adductor hiatus, which is essentially like if this is your adductor magnus, excuse the bad drawing, there's like there's a hiatus, a hole, I guess, or like an opening between the two parts of the muscle. Remember, adductor magnus has obturator and hamstring part. Between those two parts, you have a little opening because it's two separate parts of the muscle. And so in that opening, that's called the adductor hiatus, which is what it passes through. So this is the clinical point again. This is the fracture of the femur. As you can see, it's from the surgical neck here. Let me actually remove this marking so you can see it again. Okay. Again, so just have a look at it, have a really good look at it. You can see that it's broken right at the femur, femoral neck, sorry, and so medial circumflex femoral artery is at risk. Moving on, we come to the knee joint. So we're done with the thigh muscles. I hope they were clear. Yeah, okay. Oh, okay, wait. Sorry, I'm just going to have to move to the side. Okay. Then we come to the knee joint, and the knee joint has some important details to them. Most important are the ligaments and any clinical scenarios related with them. Obviously, the knee locking and unlocking mechanism is something important, and it has been discussed in lab. I think it's more important in terms of MCQs and SCQs, and in terms of understanding. It's not usually that heavily tested in OSPE, and it doesn't really have much grounds to be. So we'll come to the knee joint now. Just orient yourself. This is your femur. This is your tibia. And this is your fibula. This is the medial side, and this is the lateral side. So when we talk about the ligaments involved here, you have the medial collateral ligament, also known as the tibial ligament because it's on the tibia bone and it's connecting the ends of the femur and the tibia. And then you have the lateral collateral ligament or the fibular ligament, which comes from the bone they're attaching. And so this is fibular collateral ligament or lateral, and they're attaching again said bones to the femur. Then you have the lateral meniscus, which is like a disc, which is between the femur and the tibia. And so you have a lateral meniscus and you have a medial meniscus, and they're disc-shaped structures. A meniscus just because of what they're shaped like, which is like this is a meniscus. That's why they're called as such. And then on the posterior aspect of it, you have the anterior and posterior cruciate ligaments. Cruciate means X or like something that's making a cross. So they're crossing over like this. Anterior because it's moving to the anterior aspect of the femur, and posterior because they're moving to the posterior aspect of the femur. These ligaments are important clinically in terms of tears and like injuries, and again, very important for MCQs and SCQs, and sometimes also for OSPEs. So again, joint, you have to tell what joint it is. So this is a complex hinge joint, and it's stabilized by the ligaments, sorry. So it's a complex hinge joint. Ligaments, as I mentioned, you have the ACL, you have the PCL. Now, their functions are important and they can be tested. So what is the ACL doing? The main thing it's doing, it's preventing anterior translation of the tibia. So it's preventing the tibia from moving too anterior to the femur. And it's also adding rotational stability. And this just tells you where they're attaching. You don't really have to worry about explaining in OSPE what's attaching where. This is for your own understanding. Same thing for a posterior cruciate ligament. It's preventing the tibia moving posteriorly as compared to the femur. And it provides central knee stability as compared to ACL, which was giving rotational stability. Then you have the medial collateral ligaments. It gives medial stability, so it's resisting stress that's being applied medially. And then you have the lateral collateral ligament, which is resisting stress that's being applied laterally. And we'll come to some clinical stuff here now. In terms of what you may have in OSPEs is they might show you the drawer test, or they might they might show you the drawer test, the anterior drawer test, or just a picture of the test being conducted, and they might ask you what ligament is being tested. This is something that has been asked. So that's what you need to know. So know your tests. These are again from your basic material that you're covering for MCQs. PCL injuries, they could ask how this type of injury is brought by because it's pretty distinct. There's a direct blow to the front of the knee. And then you have the posterior drawer test as well. So you need to know the difference between the tests, and you need to be able to tell which is testing for what ligament and what their signs are. Now, MCL injuries, medial collateral ligament injuries, these are obviously, we have the unhappy triad. We'll come to it in a bit. And then we also have lateral collateral ligament injuries, which is when you have a medial blow to the knee. So here we come to the unhappy triad. Here you need to note that the force is being applied laterally. And the lateral collateral ligament isn't being damaged. It's fine. It can resist this type of force. But the medial collateral ligament is the one that ends up being torn. And with that being torn, the medial meniscus goes with it, as does the ACL. So this is just unhappy triad. These three things go together. They might ask you, they might show you that, this person was, like they had force attached. They might give you this exact picture maybe, or something similar. Obviously everything covered. And they'll say, okay, this was the damage done. State the ligaments that would have been damaged in this, or state the ligaments that would have been spared in this. So you need to know those, obviously. And now we're going to move on to the leg muscles. Um, so again, for leg muscles, you have an anterior compartment, a posterior compartment, and this time a lateral compartment. So it's like this: anterior, posterior, lateral. And again, function depends on the compartments mostly. So the anterior compartment of the legs will be responsible for the dorsiflexion of the foot mostly, and some inversion. And so that means, like, okay, technically ignore the horrible drawing, but if this is your foot, dorsiflexion is this, plantar flexion is this. Just to know. So now let's come to the specific muscles. You have tibialis anterior, and then these ones, they're similar to, in terms of naming, to what you learned in upper limb. So like in upper limb, you have extensor pollicis longus, which is for the thumbs. Here you have extensor hallucis longus, which is for the big toe. Very similar in terms of like naming, and I guess technically parallels function as well. And digitorum longus for the rest of the toes, and then fibularis tertius. So we'll see them here. Starting with the tibialis anterior, it's this muscle. So this entire thing here, tibialis anterior, it's also overlying the tibia bone. That's why the name is there. And it's coming here and it's attaching to this bone right here, a specific bone of the foot, right? And so this helps you in identifying the muscle. If this is seen on a cadaver, then you follow the pathway of the tendon and you try to the best of your ability, see where it's attaching to recognize that this is tibialis anterior. And then you have extensor digitorum longus, which is this one. This is extensor digitorum longus. Pretty much like it would appear, at least from the top part, like really near to tibialis anterior. And it's going to be giving branches, or it's going to be giving, sorry, tendons to the rest of the toes. And then between those two, a very like briefly seen is extensor hallucis longus, which is coming to the big toe. Then on the more lateral aspect, you'll be able to see the fibularis tertius, which is, yeah, it's mostly like right here. It's like this small part. It's really close to extensor digitorum, but the more important muscles are digitorum and hallucis longus extensor. And then we come to the lateral part of the leg, so which is here, right? I'm sorry. It's more on, sorry, right here. So here you have two muscles of importance, fibularis brevis and fibularis longus. As the name suggests, fibularis longus is right here, and it's longest because of its very long tendon. So the muscle itself is pretty short, and then it has a long tendon for its attachment. And then you have fibularis brevis right here. Fibularis brevis is slightly above extensor digitorum longus. I'm going to remove the presentation markings so you can have a better look at them. Okay, here we go. Fibularis brevis is right here. It's next to the tendon of fibularis longus, and it's like right between fibularis longus and extensor digitorum longus. So it's like sandwiched between those two. And brevis, if you look here, has a very short tendon. And then you have, and then that covers the anterior and lateral part of the legs. Lateral part is supplied by superficial fibular nerve. So this is important to note. Nerve supplies are always important. These are the basic ones. Anterior compartment of the leg is supplied by the deep fibular nerve, and the lateral part of the leg is supplied by the superficial fibular nerve. I'm talking about motor sensation. Every nerve that I've mentioned so far is for motor sensation. Also important to know sensory sensation and obviously know the nerves, which are exceptions. Exceptions are always important to note. So nerves that are only sensation, there are some, but I haven't mentioned them in this OSPE review. In case they weren't taught, but they are important if you have been taught them. Then we come to the posterior compartment of the leg. Now you have superficial muscles and deep muscles. So you'll see the deeper muscles once you retract the superficial muscles. But superficial muscles are usually the more important ones. So you have gastrocnemius, soleus, and plantaris. And then these muscles are exactly identical to the anterior ones, but now their names are changed. So instead of tibialis anterior, it's tibialis posterior. Instead of extensor, you have flexor. We'll see, we'll come to them here. So we don't really have, I don't have the retracted image. I hope you guys have one, I'm sorry. But gastrocnemius, pretty obvious muscle. It has two heads, and that's how you recognize it. And then right behind gastrocnemius, you have the soleus muscle. So you retract it slightly, and you'll be able to see the soleus muscle. And that's it. The other muscles, even when we were taught, we weren't taught them in that much detail. But in case in your model, you see that the gastrocnemius two bellies are not visible, and you can't even see the soleus, which soleus just looks like this. So if you can't see these two, then you're probably much deeper, and so these are your muscles. Again, you'll be able to identify them from where the tendon is going. So flexor hallucis longus is going to the big toe, digitorum longus is going to the other toes. Sorry. And then moving on, we'll come to the arteries. So okay, we're now looking, so we'll start with anterior. So you have the anterior tibial artery right here, which is running very close to the deep fibular nerve, which is what was supplying the anterior compartment. Anterior tibial artery, once it reaches the foot, it becomes dorsalis pedis. A very important clinical correlation, which is that you can feel a pulse here. If you can feel pulse here, that means the upper regions are also intact. Then we look at the posterior aspect, which is the popliteal artery, which is from the femoral artery, right? So the popliteal artery, it's coming down. Know the contents of the popliteal fossa for your MCQs. In terms of lab OSPE, it's not the most high yield, but I don't want to make any promises. But from what we learned, it wasn't the most high yield, but know it regardless. This OSPE is mostly just for basic, brief concepts. Then you have popliteal artery, and it's traveling down, and these are its branches: anterior tibial, fibular, and posterior tibial. You need to know that it's running in close proximity to the tibial nerve, and they're supplying the posterior aspect of the leg. And that's pretty much it for arteries. And then we come to bones of the feet. We're almost done, by the way. There's very little left. Just bear with me. Bones of the feet. Okay, let's begin. There's obviously the medial aspect and the lateral aspect. Always try to orient yourself. So starting off, we have, okay, actually, let's start with this diagram. So this diagram, number one and number two. So let's start with number two, actually. So right now, the foot that we're seeing is the left foot, this one. This is the left foot, and we're looking at the part with the big toe, so it's here. So from this view, you can see the calcaneus bone, which is the large bone. And then right above the calcaneus, you have the talus bone, and the talus bone it's in communication with the tibia. Remember, we're looking at it from, we're looking at the medial part of the foot and the leg. So now this is in communication with the tibia. Now we'll come back to image one. Image one, so starting off, first bone right by the metatarsal on the medial aspect is the cuneiform. And so there's technically there's three cuneiform bones, like these ones. And they just go together. You don't have to know them separately, just the three cuneiform bones. Obviously, this is the first one that's right under the first metatarsal. Right behind the three cuneiform bones, literally parallel to them, you have the navicular bone, which is this. And then on the lateral aspect of the foot, you have the cuboid bone. So you have now the bones that are making the foot. You have the calcaneus, the talus, the cuneiforms, the navicular, and the cuboid bones. And that's mostly it. And obviously you have the phalanges and the metatarsals, and these namings do come more naturally. You should have some idea, and we'll come to them when we come to the ligaments of what bones are in communication with what bone. So the ankle joint. So now again, medial view and lateral view. These obviously contribute to what we're going to learn. You have the deltoid ligaments, which are for the medial aspect of the foot, and you have the lateral ligaments. So let's go step by step. The ankle joint, which is a talocrural joint, is a synovial hinge joint. Pretty simple. It's just a hinge joint, and it's synovial. Yeah, I don't have to get into detail of that. Now, the medial or deltoid ligaments, there's three. Tibio-navicular. So as the name suggests, it's between the tibia and the navicular bone, which was something that's right behind the three cuneiforms. Then you have tibio-calcaneal, which is the really big bone at the end of the foot, so between that bone and the tibia. And then tibio-talar bone, which is between the tibia and the talus bone, which is overlying the calcaneus. So let's look at it medially. You have this, okay, let's start labeling it, right? You have the metatarsals here, and this is your cuneiform. Right behind the cuneiform, you have the navicular. This is your what's it called, calcaneus right here. And yeah, over this I would say is the talus bone, right? So if you look at the ligaments, it's not clearly shown in this diagram, so I'm just going to skip it so not to confuse you. You should have labeled pictures of the model from lab, and we have a question on it coming up soon, so hopefully it'll be clearer there. Then we look at the lateral ligaments, which is anterior and posterior talofibular, as the name suggests, between the talus and the fibula now, and the calcaneofibular. So it's pointed out here, the calcaneofibular. This is the fibula, this is the calcaneus, and it's between those two. And you also have the posterior and anterior tibiofibular. So these are between the tibia and the fibula, between those two, posterior and anterior tibiofibular. Those are the other lateral ligaments. And then here you can see a better depiction of the talofibular ligament. So fibula, and this is a talus bone right here, so between those two. I hope that was clear. If you have any questions regarding it, do let me know by message, and I'll try to clarify it further there. But yeah, these are from the images that I could get. Again, important nerves in this overall area. It's not specifically related to the ankle joint, but it's just something that I think was important to bring up. Remember the deep and superficial nerves, deep and superficial fibular nerves that are supplying for sensation in this case. Note that the deep peroneal, which is another name for deep fibular, is supplying the first web of the toes, for instance, in terms of sensation, and then the rest is the superficial peroneal for this part at least. And then you have saphenous and common peroneal. Saphenous is supplying the medial aspect of the leg in terms of sensation, and common peroneal is applying a little above the superficial peroneal, and again more of the lateral aspect. And then we come to the last concept of this OSPE review, which are the foot arches. What you could be asked is just name some bones that are making up a specific arch, and or like which could be damaged in, say, flat feet or so on and so forth. So this is purely memorization, obviously understanding as well, but in this case, from my perspective, just memorize it. Bones that are making up the medial arch are the calcaneus, the talus, the navicular, the cuneiforms, and the first three metatarsals. It's just pretty much that. And it's the highest arch, which is a characteristic feature, and flat feet occurs in people who have a problem with the medial longitudinal arch. Then you have the lateral longitudinal arch, which is made of the calcaneus and the cuboid. Again, these are the more laterally lying bones, so it makes sense. Lastly, you have the transverse arch, which is made from the cuneiforms, the cuboids, and the metatarsals. And okay, that much covers all the topics for this OSPE review. And now we'll come into the questions. Again, these are from the mock OSPE. And yeah. So pause and think about it, and I'll be moving forward with the answers. So what makes the medial boundary of it? Adductor longus, which is a muscle that we did cover. I'm sorry that I didn't mention it on the diagram when we were labeling it, but You can't see it in this image, but this is something you should know from your lecture content, which is making up the medial boundary of the femoral triangle. Contents, as we mentioned, are van, medial to lateral, or lateral to medial, the other way around. Next question. And then we move forward. Again, these are just basic bones that are making up the medial longitudinal arc. You can mention any of them and just make sure to focus on the number that they're asking. And the muscle tendon that was attaching right here, I hope you saw it when I was explaining it on the model, but this is again just anterior tibialis, which is coming over the tibia and attaching right under this bone, right? And so that's the tibialis anterior. And then this is an important one. These are fractures. This is a clinical topic, and this is something that can come in OSPEs. And so just think about it and pause, and I'll be moving forward. Now this is something that's known as Potts fracture. Pretty much everything is broken here. And this is a problem with the ankle joint, right? And literally almost everything is damaged here. So deltoid ligaments are clearly damaged, so those are the ones that we mentioned. Tibia talar, tibia calcaneal, tibia navicular, damaged for sure. Other things that are broken here, if you can look at the X-ray, you can see that the malleolus is fractured right here. The fibular bone is also broken here. It's just a fracture of almost everything. And then we come to this question for the knee joint. Think about it and we'll move forward. I hope you can see the labels clearly, by the way, X and Y. This is the femur, this is the tibia, the fibula. So this is lateral, and this is medial collateral ligaments. And then the test that's used to test for ACL is an anterior drawer test. Sometimes they might show you a picture of someone conducting the anterior drawer test, and they might ask you which ligament that is. I think I mentioned that before. Just remember to focus on the tests. And that's it. That's the MSK OSPE review. I really hope this benefited you. Some tips I would just give is try to solve past batch questions, try to solve practice questions. So if solve the ones that are on your lab committee drive, because obviously those are the most relevant to you. If you've solved them and you still want to practice more, you can go to the 15th batch lab committee drive, because we did upload some like topic-based OSPE questions. Take those with a grain of salt, if you will, but do solve those. And just if you know your general material, the lab material should come in somewhat easily too. Again, if you have time, go over Dr. Atif's videos just to see what the muscles look like on the cadaver. But that's pretty much it. I hope this benefited you, and all the very best.